introduce my panelist. I am the moderator. So panelist is Dr. Rohit Swami. Hello, Rohit. Hi.
Good evening, sir.
Good evening. He is a consultant medical oncologist in the Narayana Multi-Speciality Hospital, Jaipur. Dr. Siddharth Turkar, Director, Radiant Super Speciality Hospital in Raipur. I guess he has messaged us like he might not join today. And Dr. Preeti Agrawal, he's a consultant medical oncologist in Apex Hospital, Jaipur. Dr. Rekha Bansal, consultant medical oncologist, Apollo Hospital, Hyderabad.
So Dr.
Welcome,
Siddharth has joined.
Yeah, okay. Thank you. Thank you. Dr. Siddharth. Okay, so I'll share my presentation. Okay, so
hello sir, I'm here actually. I'm here, Dr. Preeti.
Yeah, Dr. Preeti, I introduce you. You are the consultant medical oncologist at Apex Hospital, Tata, very near, Apex Hospital, Jaipur. It's very nearby to us, and we'll start. Both the previous speaker have presented their presentation on the maintenance therapy of the ovarian cancer. So we will try to briefly touch upon some practical issues, and their presentations were very clear how to go about, but still we will sort out. And this presentation is sponsored by, this talk is sponsored by AstraZeneca, and I thank them to giving us the educational grant. So we'll have a very common case which we find in our OPD. This is a 49-year-old lady presented to the complaint of abdominal distension and nausea. Usually they present like this only. The medical history was chronic hepatitis B and hypertension. Family history was patient's mother died of breast cancer at the age of 59 years, and a cousin on her mother's side had ovarian cancer at the age of 65. CT scan was suggestive of ascites and bilateral 8 cm adnexal mass. They were bilateral, and CA125 was 285 units per ml. So I'm just reading out why, because we are not discussing the treatment part, we are going to the maintenance part. So she underwent exploratory laparotomy followed by omentectomy, bilateral salpingo-oophorectomy, pelvic lymph node dissection, appendicectomy, and resection of the pelvic nodules. And she had ultimately the stage 3C, high-grade serous ovarian cancer, and she had optimal cytoreduction. There was no gross radius disease left in the abdomen. That time we didn't do the germline molecular testing. She was treated with the standard carbopacly regimen for 6 cycles, and patient shows no evidence of disease. She was in the complete remission, and now this patient is referred to you. Means we will talk about the further treatment. So I will start with Dr. Rohit. He's top on the screen. So Rohit, he is my junior, so I can call him Rohit. So Dr. Rohit, how you will proceed further? Because we have listened the talk of Dr. Akhil, Dr. Rakesh. So nowadays, earlier also, I admit, like we were not sending the enough molecular testing and all that, but now we started sending. So how you will proceed in this case? It is a very standard case we are getting every day, day in, day out. So how you will proceed?
So sir, this patient is having a significant family history and has developed a high-grade serous ovarian carcinoma at the age of 49 only. So mostly she is HRD positive or either BRCA1 or BRCA2 positive. So I'll definitely go for germline testing in this patient, and if she comes out positive for HRD or BRCA1, BRCA2, then I'll start maintenance therapy with PARP inhibitors.
Okay, point well taken. So Rohit, actually I was also filtering the patient because we have always cost constraints. So I was filtering the patient by asking their family history. Do you have their any family members in maternal or paternal side affecting the cancer? But as we have seen in the previous talk, like the patient if they don't have the family history, still they have a 20-30% chance of having positivity. So I will also correct myself, like we should not ask the patient to just have a family history and then send. We send means like across the board, right? So Siddharth,
Definitely,
please.
sir. We should send it in all ovarian carcinomas, but in this patient, she is having significant history,
Yeah,
so
yeah,
I mentioned.
that is there. So Dr. Siddharth, you please unmute. Siddharth,
Yes, sir.
welcome. Yeah. So Dr. Rekha, please unmute yourself. Dr. Preeti. Okay. So Dr. Preeti, I would move towards you. So would you agree for sending the patient for BRCA testing, or are there some challenges you are facing in your day-to-day life?
So yes, I would definitely want to send every patient of high-grade serous ovarian cancer for BRCA testing, but the limitation is the cost. The cost of the drug test is also okay, but whether this patient is going to afford the PARP inhibitor or not, that is also a choice. That is also an important factor to keep in mind before sending the test only.
Yeah, exactly. The cost is an issue, but see, now some government schemes are there where patient can avail the PARP inhibitors. So we are a
Yes.
little bit free our hands to send the testings. So I would move to Dr. Rekha Bansal. She's from Hyderabad. What is there in your city and your scenario in your hospital? Are you sending your old patient for genetic testing and or some other advanced testing? What is there, Dr. Rekha?
So, sir, because in the trials they actually used HRD testing, and we don't have HRD testing is as such very expensive. At least a BRCA test, I'm definitely sending, sir. With the coupons available, the cost has drastically come down. Even if the patient can't afford the treatment, it adds to our clinical knowledge. What is the actual prevalence of the mutation? So, and it helps us predict the prognosis also. So I definitely try and send for, I think 80% of my patients are now willing to at least undergo the test, leave alone the treatment. And for now, BRCA mutation, I'm sending, sir. HRR, I have sent for few patients. HRD, I have not sent for any patients, sir.
Siddharth, you unmute yourself.
Yes, sir. Right now, as we know, there are some patient assistance program for testing at least. So, like MedGenome is doing HRD testing through coupons also. So we are more inclined to send at least the HRD testing for all of our patients. But still, I agree with Dr. Preeti that many of the patients are not affording, and sometimes it is very difficult to complete chemotherapy itself. But by preference wise, every patient is being counseled for the same.
Yeah, thank you. So means like since last 6 to 10 years, 6 to 8 years, we were just listening about the BRCA testing. Now we are sending very frequently the BRCA testing, and now we are thinking of HRD testing. And last week only some lay people came, 2 or 3 companies. They've just promised like they are doing HRD testing. I guess their labs are validated because they are well known in India and some southern part of the Asia. So they are saying like it will be done in 45,000 in the concession rate. So if that is the case, then we are a little bit more privileged to have this test. 1 year back when I asked this test, this HRD testing, they told me it will cost you around 4.5 lakh rupees. So I put myself in the, you said, deep blanket and then just rest. But now the scene has changed. So everyone agrees like we will send the test for BRCA and HRD if it is available. And I heard like AstraZeneca people are doing this test nowadays. So we'll ask further. So this was the standard therapy. We have seen like patient up, if the upfront surgery is possible, it's well and good. No, then give chemotherapy, debulking chemotherapy. Then again, if upfront surgery was done, debulking, then give chemotherapy, and there is a chances of remission. And generally the disease is platinum sensitive, but the problem comes when we are worried about the recurrence. So I just want to ask Dr. Rekha Bansal, in your clinical practice, in your scenario, in the real world situation, how many patients of yours present in which stage, number one, and how many after the treatment will relapse in some point of time?
So most of the patients present, at least in 3, sir, I think I would say 90% of my patients are in stage 3C, at least they are with ascites. And so relapses, because it has a bad prognostic and not everyone can afford the olaparib, and this evidence is relatively new. So most of the patients eventually relapse, I would say within a year, sir. Yeah.
Yeah. So almost 70% patient relapses, and the irony of the system, our system, and the disease itself, because it is an intra-abdominal disease, intrapelvic disease, so it presents very late. So 70% patient present in the stage 3C and onwards, 3B or 3C, and then they relapse very fast. So our country has this kind of the patient burden, and now we want to improve upon that. So it is a little bit tough. Once I was there with Dr. Arvani, just I am telling you some small story. One patient came very influential, and they were argued like कि disease वापस कैसे आ गया, हमने तो इतना बड़ा surgery करवाया. So straight away he said, if patient has a stage 3 disease, in some point of time disease will come back. So there is no point in discussion. You discuss the further treatment. So that was the case. Okay, so here, Vikrant, so I have asked you and advice of the test. So now we have a different option about the maintenance, giving the maintenance therapy. So you all agree in the first line setting where patient has completed the treatment and patient is in CR, you want to give some sort of the maintenance therapy. Is it correct? Is it like overstatement, or it should be improved? So I will come back to Dr. Rohit. What you will do in your practice?
So,
it just
sir, if
change
the
of ideas.
yeah, so if the patient is on not the high risk of recurrence, like the disease is stage 1, stage 2, we have given chemotherapy as per the stage, and we have done the R0 resection, then observation is a good option. If a patient is having stage 3C and stage 4 or strong familial history, then I don't think that observation is a good option. Even the patient is in CR after primary treatment as well as after chemotherapy. So in that case, if chemotherapy was given along with bevacizumab, then I like some sort of maintenance with bevacizumab. And if patient is HRD or BRCA positive in stage 3C or 4, and if there is a familial history, then I will go with PARP inhibitors as a maintenance. So I like to give some kind of maintenance in a disease where there is a high risk of recurrence.
Okay, point well taken. Dr. Preeti, I would just move forward to you. Dr. Preeti.
Yes, sir.
Is your opinion is different? Like Dr. Rohit, like patient has a good prognosis because patient had R0 resection and was in CR, received abdominal treatment. So now he can observe the patient. So is there, is your opinion is different?
No, sir. My opinion is similar to Rohit sir's opinion. So I would definitely like to go for some more other form of maintenance. Patient is HRD mutated or BRCA positive, then I would definitely want to go for PARP inhibitor as maintenance. So some or other form of maintenance of is required for this patient, even the patient is in CR.
Okay, so in CR you want to give some maintenance, right? Rohit
Yes.
didn't wanted to give some maintenance, so there is some difference. Dr. Rekha, what would be your opinion?
So, sir, I use bevacizumab only in certain set of patients, not every patient. So, if the patient is receiving bevacizumab in the neoadjuvant or in the adjuvant setting, and then and if BRCA mutation data is not available, then I at least try to continue bevacizumab. And now, like I said, I'm encouraging more and more tests. So, if I come across the BRCA mutant patient, then olaparib is offered. And if it's HRD, by the guidelines, I mean, by the data, we are supposed to give both bevacizumab and olaparib. Currently, I don't have any patient which is fitting into that criteria, but I would like to do that.
Okay, your point is valid. Dr. Siddharth, what is your take on this?
Sir, if the patient has
It's very
R0
critical question. Everyone will ask. The patient sometimes ask कि हमें और भी कोई दवाई लेना चाहिए क्या? we have read on the Google or we have taken the opinion from abroad. They are asking to start some therapy which is which is called as maintenance therapy. They come to us and they want our opinion. So what will be your opinion?
Sir, if the patient is HRD positive, then definitely I will go ahead with PARP inhibitor, because in second line setting, as we know, most of the patients are not able to take any maintenance, and many patients are not able to take second line also because their PS deteriorates. So better to give a PARP inhibitor upfront so that we can maximize their benefit. Second thing, if the patient is not HRD positive, regarding continuing with bevacizumab, I would prefer it only in R positive resection. In those who have R0 resection, I would not like to give bevacizumab as maintenance.
Okay, Dr. Rekha was also telling me like if patient had been started on the bevacizumab, she will continue. And there are some trials in which they have shown a subset analysis. They have shown like if the patient has a stage 4 disease upfront, very heavy burden disease, then bevacizumab can improve the overall survival by 10 months. So it's a good idea to give. Other than BRCA, which test you want to do, Dr. Preeti?
HRD, I want to do.
Okay, HRD you
Yeah.
want to do. So BRCA will constitute around, like Dr. Akhilesh said, 7 plus 15. It is around 23%, and rest you may say like 30% around will be HRD positive. The total chunk is around 50% patient will be some mutation positive, which you can target, right?
Yes, sir.
Okay. So Dr. Rekha, can you tell us, like patient is HRD positive or BRCA positive, whatever it is, what is the significance in first line setting? If you want, if patient is treated like this and you got some test positive, so how do you take it?
So,
Like BRCA negative or HRD positive?
So for BRCA negative, HRD positive, based on the SOLO-1 data, olaparib is not recommended, sir. We need to combine, based on the POLO data, we need to combine bevacizumab and olaparib in such patients. So that is the difference that would come.
Yeah, very well pointed out, and very short. And very short. So this is the testing slide. Really, sometimes we get confused how to do, when to do. So germline testing, that means like 15% patient are inherited BRCA mutation. BRCA in tumor, like somatic mutation, are 8%. So roughly 23 or 24%. 5s are other. 5% patient don't have the BRCA mutation. They have the some other mutation which can be targeted. These are, you can see, these are the RAID 51C, RAID 51D, and PALB2 and BRIP1. These patients have shown the good effect with the PARP inhibitors. Still, they are not included in the this guidelines, but the data suggests like they can be targeted with the PARP inhibitor, and the results are very, very good. So if we do the NGS type of the test, we can pick up this kind of the test or some HRD testing, right? There is no reservation nowadays. So what is HRD testing? I will just read out. Homologous recombination deficiency test. HRD is a measurement of the defective DNA repair. Mutation in the BRCA and other HR gene leads to HRD, both together. Sometimes predictive of PARP inhibitor response, but the best predictor is having the BRCA mutation. So if you compare with HRD positive and BRCA positive will have the phenomenal response with the PARP inhibitors other than the HRD, but they are somehow in between. If patient is wild type, they will be the least responsive, then the HRD positive, and the most responsive will be the BRCA positive. So HRD assays look for changes in the DNA from having HRD at some time. So sometimes this was somehow reflected in the talk of Dr. Akhil also. They keep on changing. If you see the patient one point of time, other point of time, they may be changed. So we need to take care of it. Okay. So I asked the question to Dr. Rohit also. Platinum combination chemotherapy. One option is observation till next relapse, or platinum combination chemotherapy you are given the first line. We can give the PARP maintenance, or platinum combination chemotherapy plus bevacizumab maintenance. Dr. Preeti had said, or platinum combination chemotherapy, bevacizumab, then you can continue with the bevacizumab plus minus, but PrAP inhibitor you can give. So these all four are options. So which is more suits to you? We will see that. So stage 3 epithelial ovarian cancer after 6 cycle paclitaxel, just a minute, to your OPD for further management. So how you will say this is we have discussed, so no point in discussing that. So this is the summary of the trials which I want to, because time is short, I want to narrate with you. If you want to give upfront maintenance, there are some trial, olaparib trial, solo one trial, which have taken the patient mutated, unmutated, but the patient who derived the most benefit was the mutated patient. And if you see, if you talk about the trial in the recurrent setting, it was solo 2, which tested olaparib and got the good PFS benefit. And if you see, if you want to give to the anyone like BRCA mutated or unmutated, HRD positive or negative, then these trials are Paula trial, olaparib plus bevacizumab, Villa trial, veliparib, Prima trial, niraparib. These are approved drugs. So study 9 in the recurrent setting, olaparib, Nova trial talked about the niraparib in the recurrent setting, and Ariel 3 trial, rucaparib in the recurrent setting. And the classical drugs, anti-angiogenetic drugs, which were used in the maintenance was GOG, with the evidence came from the GOG 218 trial, chemo plus bevacizumab, GOG 213 trial. We every time we say like it was a 3.1 month benefit with this trial, but it was states wise it was significant. So it is we keep on talking about that. GOG trial 213 chemo plus bevacizumab arm, on Ocean trial gem carbo plus bevacizumab arm. And these were the FDA approval for the upfront maintenance, olaparib in the BRCA mutated. If patient has BRCA or HRD positive, then olaparib is approved by FDA with the bevacizumab, and anyone you can give niraparib with the evidence came from the Prima trial and bevacizumab from the older trials, right? And recurrent setting, olaparib, niraparib, rucaparib, bevacizumab are approved. So these are the some flowchart which you can avail. In this patient show no definite evidence of the disease, complete response, and underwent molecular testing, and she is BRCA mutant. So we are talking about the first line setting. If patient is BRCA positive, BRCA1 positive, so which kind of the which drug you want to give? So I will ask this question to Dr. Rohit. Rohit, you will give olaparib or niraparib?
So, sir, I will go with olaparib because the niraparib trial has certain selection bias, and basically they included the population was mainly high risk in those patients as compared to solo one trial. So I will go with olaparib.
Yeah, good. Thank you. And Dr. Rekha, what is your take? If both the drugs are available, patient is BRCA1 mutated, and you have seen the case like optimally treated in remission, so you want to go with olaparib or niraparib?
Olaparib, sir. This patient represent the solo one population more than the Prima, so olaparib, sir.
Okay, point well taken. Dr. Siddharth?
Same thing, sir. I agree with for olaparib.
And Dr. Preeti?
Similar, sir. Similar. Agree with everyone.
Yes. So out of 4, 100% are with olaparib. So AstraZeneca people will like it. Okay, but niraparib has a indication if you you don't have the testing reports and all that. So we should keep in mind. Slides are not moving. Okay, this slide had shown by Dr. Akhil Kapoor also, and I am also showing that. So you can see that at 5 years survival difference was 56 months versus 3.8 months. So almost this if you pick up like 15 months, it was 56 months. So it is a very significant difference if you give the olaparib maintenance. And as he has pointed out very clearly, at the difference started at the 3-month interval when we generally want to first follow up the patient. And this graph becomes wider and wider, and it is still continued. So it is clearly shown the benefit. And we will, if the patient is affordable and the mutation is positive, we should give the olaparib if they are affordable. There is no doubt about that. And would you have preferred to give bevacizumab along with the paclicarbo as a part of post-primary therapy if she was diagnosed at your center? So the question basically asks about the VEGF inhibitors. If patient is say about we don't have the testing results of the germline and somatic testing, and patient is affordable to the bevacizumab, because generic bevacizumab nowadays is 15,000, 20,000 every 3 weeks. So would you like to give that, Dr. Rohit?
So, sir, if patient is of stage 3C, like in our case, and if she was started on paclicarbo with bevacizumab, then I'll definitely continue bevacizumab. And if the patient is in CR and if she is BRCA negative or HRD negative, and then I don't think that there is any benefit of adding bevacizumab in the maintenance only if she has not received bevacizumab initially also with chemotherapy.
Yeah, so this was the famous GOG 218 trial analysis, subset analysis, and these were the data after the 9 years, and they have shown like the patient who have a stage 4 disease, pleural effusion or some parenchymal mets, they have derived the good benefit out of this bevacizumab based chemotherapy. And so this is again the things are common. Paula study Dr. Rekha Bansal was talking about. You see like tumor BRCA mutation was 29% patient were positive for that. HRD in total was 48% and 19% were this genomic positively. I want to ask you, ever you got one patient like who were somatic mutation positive and germline negative? Any one of you got this kind of patient, or it is like in hypothesis also? Dr. Rekha?
No, sir. I have two patients who are germline positive, sir.
Yes, germline positive, or maybe somatic positive and germline both positive. But rarely it can be like patient is germline positive, somatic positive, but germline not positive. So this kind of the situation will come when we test like hundreds of the patient, but it is there. So most of the things were covered in that presentation. So I would ask you about this is the important slide which Akhil has also told us. Tumor mutation positive, tumor BRCA positive, like somatic mutation positive derived the best benefit out of the set. And if HRD is not known or HRD negative, not known means some patient will be positive, so they will get benefit, but not positive, then the benefit is not significant, right? So we will be seeing this. These are the data. So now I would little bit focus about the side effect of the PARP inhibitor. So we have all given and started giving olaparib in our clinical practice. So
Dr. Aseem sir, extremely sorry to bother you, but last 1 minute to conclude.
Yeah, so just last one slide. Just one question last. Preeti, I want to ask you, which side effect is most bothering you in your clinical practice with the olaparib?
The anemia, fatigue and anemia. Anemia is the most bothersome side effect which we all face. Anemia is the bothersome side effect which is clinically bothersome.
Okay, Dr. Rekha, can you highlight something?
Yes, sir. Anemia and thrombocytopenia. Basically, sir, I have had a patient with bad thrombocytopenia.
So, how many patient you had to reduce the dose of olaparib? Suppose you have started in 10 patient. Out of them, how many have reduced the dose?
I would say 7 patients, sir. So.
That's exactly, because in Indian setting, patients are so weak. They are elderly ladies from villages and all that. We need to reduce the dose, and then also they are having the side effect. So, Dr. Rohit, how many of your patients are having diarrhea or fatigue or anemia? Is it very common or is it less common?
Actually, sir, most common is anemia and thrombocytopenia, and that is the reason to reduce the dose. But definitely diarrhea is also there. but thrombocytopenia and anemia is the only cause which led to a decrease in dose in these patients.
Okay, so we will not touch upon this other studies of Rucaparib and all that, but still we all are agreeing that there are some side effects of bevacizumab also and PARP inhibitors also. So I will briefly touch upon. Bevacizumab can cause high blood pressure. We need to be very aware of that because patient as it is elderly ladies and they have some blood pressure issue unnoticed, and we give bevacizumab and it will flare up. So we need to check it. Sometimes it causes sinus issues, maxillary sinus and all that, and some voice changes, muscle and joint pain, which we attribute to the poor nutrition, but it is because of drug also. Sometimes they have the blood clots or some thromboembolic phenomena. So we need to address it very early because sometimes embolic infarct can convert into the hemorrhagic infarct. Bowel perforation fistula is well known and fatal, almost fatal complication. So these are the things. And PARP inhibitor have a low counts, nausea, fatigue, and MDS and leukemia. So in solo 2 data, 8 years data, the impact of this MDS and leukemia was 8%. So we need to be aware of that. And thank you very much for being with us. And I thank all the panelists for their informative comments, and my organizing team and team backstage, Mr. Tarun and Gitika and Ekta Mathur madam, and Dr. Tarachan, who has given the scientific inputs about setting the agenda, and our all pharma and academic partners. I thank AstraZeneca for this session especially, and thank you all. And we will meet soon with very small meetings, and I would be happy to part of your meetings also. So thank you, Dr. Rohit, Dr. Rekha, Dr. Preeti, and Dr. Siddharth. Thank you very much. Goodbye and good night.